Hi everyone, Nursing It, and back with part 2 of Obstetrics for Paramedics, and in this second part of our summer lecture series for EMS, talking about some complications that can arise in our obstetric patients and in our newborns. The most common medical complaints that you will get called for during pregnancy include bleeding, pain, nausea and vomiting, blood pressure problems, either too high or too low, and then either new onset or worsening of chronic medical conditions. And these would include respiratory problems, endocrine problems like thyroid or diabetes, cardiovascular problems, or neuromuscular problems. Bleeding can be from like vaginal bleeding, which could be related to the pregnancy or not. This also includes a spontaneous abortion, a miscarriage, and things like subchorionic hematoma, which can cause painless vaginal bleeding. The thing to keep in mind is that if this was a desired pregnancy, or if the person emotionally was connected to the pregnancy, that vaginal bleeding during pregnancy can be psychologically very traumatizing, even if the person's not experiencing pain. So your demeanor and your professionalism and your caring can have a really significant impact on the way that they respond to and process what is happening to them. Pain, especially unilateral pain, could be related to things like an ectopic pregnancy. Placenta previa and placental abruption can cause bleeding with or without pain. Things like pregnancy-induced hypertension and eclampsia can elevate blood pressure, as well as underlying history of hypertension. And then things like supine hypotension, or kind of positional occlusion of the inferior vena cava, can cause problems with hypotension, as well as hyperemesis gravidarum, which is like kind of a prolonged vomiting and poor PO intake related to nausea in pregnancy. And patients can have gestational diabetes or exacerbation or kind of difficulty controlling type 1 or type 2 diabetes that they had prior to becoming pregnant. We see preterm labor as a problem, as well as infections. And so we'll talk about some of the infections that can be detrimental to the fetus if the pregnant person's exposed, especially in those first 8 weeks of fetal development. Some of the high-risk conditions and factors that we have to consider also when thinking about things that could be complicating factors during pregnancy. Precipitous labor and birth increases the likelihood of postpartum hemorrhage and the need for neonatal resuscitation. Post-term pregnancies increase the risk of having a large baby, which increases birth trauma and the risk of postpartum hemorrhage and problems with neonatal blood glucose regulation. Meconium staining increases the risk of airway problems and the need for neonatal resuscitation. Fetal macrosomia means large baby, so that also, again, just like post-term pregnancy, increases the risk of trauma during delivery and of having a difficult time regulating glucose after delivery. Multiple gestation increases the risk of having low birth weight babies, and it just really taxes your resources. And sometimes babies are born one right after the other, and sometimes they could be hours apart, even vaginally with multiples. So that presents even a more unique complication of, do you deliver one at home and then try to load and go and see if you can make it to the hospital before the next one is delivered. But since multiples are often born early and they're often born small, it increases the risk of needing resuscitation. Intrauterine fetal demise or death, people may deliver a baby that is stillborn, and obviously that can cause some significant emotional trauma to all that are involved. Amniotic fluid embolism we'll talk about, but that presents similar to a PE, but it comes from the amniotic fluid and causes almost like an anaphylactic reaction within the blood vessels in the lungs. And then polyhydramnios and oligohydramnios are too much and too little amniotic fluid that can then lead to not only kind of trouble with the baby, but are indications of problems with either like the kidneys or problems with the GI tract of the developing fetus. And then we have cephalopelvic disproportion, and there's different types of disproportion that you can have, but essentially with this disproportion, the baby's head does not fit through the pelvic opening and needs to be born via C-section. So any of these conditions, should they occur in the out-of-hospital setting, become critical and increase the risk of kind of a poor outcome. So let's start off by talking about some of the infections that can impact the fetus. As I mentioned, the fetus is developing that rapid cell multiplication really rapidly during the first trimester, specifically in the first 8 weeks. So, weeks up to the end of week 7. And often before the person even aware that they are pregnant. So those organs are being formed and the cell differentiation is taking place. If at that point in time the pregnant person is experiencing a infection like a urinary tract infection or yeast infection or some sort of like bacterial vaginosis, and they're given antibiotics, or if they're exposed to one of the torch infections, they could be exposed to what's called a teratogen. So a teratogen is a drug, a virus, or an infection that the pregnant person is exposed to that can cross that placental barrier. And these teratogens harm the developing fetus. Pregnant people are taught to avoid unsafe medications, drugs, and chemicals, as well as hot tubs, deli meats, raw meats, cat litter boxes, and sand boxes, and sick people to limit the risk of exposure and infection. So TORCH stands for toxoplasmosis, which you can get from cat feces. Other, which includes hepatitis B, GBS, and HIV, rubella, which is German measles, cytomegalovirus, and herpes simplex virus. And then things like shingles should be avoided, and syphilis, sexually transmitted infections should be avoided if at all possible while pregnant. Hyperemesis gravidarum is the excessive or even relentless nausea and vomiting that occurs during some pregnancies, and it's believed that this may be related to a rapid increase in human growth hormone. It typically peaks at about 9 weeks and usually subsides around 20 weeks, although some people unfortunately experience this throughout their entire pregnancy. This condition is so severe that it leads to dehydration with electrolyte imbalances of hyponatremia and hypokalemia, as well as the acid-base imbalance of metabolic alkalosis from vomiting up so much of those GI acids. It also leads to starvation ketosis, so the breakdown of body tissues for energy since the person can't eat, and so they have ketones in their bloodstream, so their urine may smell like acetone. They may even get some kind of ketone breath. And then weight loss is significant, and they start losing at least 5% of their baseline body weight. Chief complaints of people with hyperemesis gravidarum are things like nausea and vomiting, lightheadedness and dizziness, Syncope is a common complaint. You'll find them to be tachycardic and hypotensive with dry mucous membranes and poor tenting skin turgor. The treatment in the field is IV hydration. We have found some success with the administration of B vitamins, specifically B6, which is pyridoxine, and then Unisom, which is doxylamine. That also tends to work on most people. If that doesn't work, we are able to give patients Benadryl, and then any of the phenothiazines like Phenergan and Compazine, or any of the benzamides like Reglan, which is metoclopramide. Those also have been successful. And you want to pair the Benadryl with those, either the phenothiazines or the benzamides, to help decrease the risk of that dystonic reaction, but also just the anticholinergic properties of the H1 blockers, because their anticholinergics also really help with the nausea as well. It's important that you do not mix Zofran with antihistamines like Benadryl, because that could further prolong the QT interval. And there is some controversy about Zofran in pregnancies, especially in that first trimester or less than 10 weeks, because it has been correlated with an increased risk of birth defects, particularly cleft lip and cleft palate. So these patients typically get hospitalized if they can't manage them on an outpatient basis with things like B6 and Unisom. Hypertension in pregnancy is a significant issue for us. So these are terms that you may have heard: preeclampsia. So that's the stage before eclampsia, and this is where the person is actually becoming toxic, like they're building up proteins in the urine and toxins in the bloodstream, and their blood pressure is getting really high. And if they call you, they usually call for one of the complaints that's listed here. So a significant headache, confusion, seizure, which would have been eclamptic unless they had an underlying seizure disorder, respiratory symptoms like shortness of breath, chest pain or cough, visual disturbances or loss of vision, nausea or vomiting, significant right upper quadrant pain, which is most likely related to HELLP syndrome and elevated liver enzymes, and then decreased urine output. So preeclampsia should not be taken lightly. If you go to somebody who is hypertensive with any of these signs and symptoms, and you recognize like significant edema, things like that, that person should be treated emergently and transported rapidly. I want you to recognize then the two things associated, and there's lots of things, but two of the things associated with preeclampsia. So the first one is eclampsia, which is a grand mal seizure related to pregnancy, and specifically kind of follows this significant hypertension and this kind of host of problems. We treat this with mag sulfate. The caveat to that is, if you have a patient who has an underlying seizure disorder, sometimes it's hard to know which type of seizure you're dealing with, and it may be worth it to give them a benzo first, because that's fast administration and fast acting, and if that doesn't work, then give the mag sulfate. HELLP syndrome is excuse me. Hemolysis, so where the red blood cells start to break down, elevated liver enzymes, and low platelets. And these patients are typically, HELLP is typically a complication of severe preeclampsia, but these patients are really high risk then for hemorrhage, because platelets are thrombocytes. Those are the cells that allow our blood to clot. In contrast to high blood pressure, we also have the complication of low blood pressure in the pregnant patient. So supine hypotensive syndrome usually occurs from compression, or actually I should say always occurs from compression of the inferior vena cava. So this occurs when the pregnant person is usually on their back in the 3rd trimester of pregnancy. In a supine position, the enlarged uterus and fetus compress the inferior vena cava, which leads to a significant drop in preload. So basically the blood gets trapped kind of in the lower extremities and it doesn't return to the right side of the heart. So when preload drops, then stretch drops, and when stretch drops, stroke volume drops, as well as obviously just the circulating volume, and then cardiac output is going to drop. So blood pressure, we have a significant drop in blood pressure. The signs and symptoms include feeling dizzy and faint, and the treatment for this is manual left uterine displacement. And left is ideal because the aorta is to the left and it can handle the pressure of the baby, where the vena cava is to the right and it cannot. This is just a picture of left lateral displacement. You may hear that we also use the term intrauterine resuscitation. So one of the things to remember is that you cannot start an IV on the baby and you cannot oxygenate the baby. And the only way to provide resuscitation to the fetus if the mother is hypotensive is to provide resuscitation to the mother. So intrauterine resuscitation includes putting the pregnant person on their left side to prevent supine or to alleviate supine hypotensive syndrome, and then oxygenating the pregnant person to increase oxygen flow to the fetus, providing IV fluids to correct any underlying hypotension, but don't give IV fluids obviously if the pregnant person is hypertensive. And then, keep an eye on the timing of contractions and transport. Manual left uterine displacement is important during CPR. So if you don't have the ability to tilt the right hip at least 15 degrees, or the person, kind of over onto their side, as you saw in that last picture, you can either be on the patient's left side and reach across and using both hands displace the uterus towards you, as you see on the right. Or if you are on the right side of the patient, then you would take one hand and you would push the uterus towards the left. Now, this is the technique that you use during resuscitation of the pregnant patient as well. And we have had some cardiac arrests due to supine hypotension where just CPR and manual left uterine displacement alone have resulted in a return of spontaneous circulation. So that's how significant the hypotension can be from this compression of the inferior vena cava, and that's how effective manual left uterine displacement is as well. So keep that in mind, that if you have a pregnant patient who is in arrest, that this is, absolutely required, and it can be a lifesaver for both the pregnant person and the fetus. Now, I want to talk about two problems with the placenta, and these oftentimes get kind of lumped together, but they have nothing to do with each other. They're just placental issues. So the first one is placenta previa, and previa, kind of thinking about the word prevalent, meaning that it's like first. This is where the placenta attaches to the lower segment of the uterus near or over the internal cervical os. Right, so the os is the opening in the cervix, and so you can see here that it's low on the lower uterine segment. So you have, in this picture, it uses the terms total placenta previa and partial placenta previa, and we've kind of gotten away from using those terms. Those are older terms, and now it's either previa if it totally or partially covers the os, or it's just a low-lying placenta if it's near the cervix but does not cover the os at all. So one of the problems with this is that as soon as that cervix starts to efface and dilate in the 3rd trimester, it is going to shear those blood vessels that are attached to it from the placenta, and you're going to have hemorrhage. So hemorrhage is really likely in that 3rd trimester. The hallmark signs and symptoms of placenta previa are painless bright red blood per vagina. However, since this is often associated with the onset of labor, pain and contractions may be present due to labor, but not uterine irritation. And that's where I really need you to draw the distinction between previa being a painless, meaning that the bleeding itself is not from a painful cause, versus when we're talking about abruption. Abruption causes significant pain and discomfort itself. So the bleeding is painless, but labor may also be occurring, and labor is not painless, right? Placenta previa is actually fairly prevalent. It occurs in about 1 in 200 pregnancies, and people have about a 10 times increased risk of hemorrhage if they have this. The diagnosis usually occurs with prenatal care and ultrasound. So again, those questions of have you had prenatal care and do you have any problems that I should know about, those are really critical, because if somebody says to you, I have placenta previa, the answer is not, hey, let's deliver this baby in the field. It is like, hey, let's drive as fast as we can safely for all of you involved to the nearest hospital that can do a C-section, because that's how that baby is coming out. The risks for developing placenta previa are having scars on the uterus or the endometrial lining, and that includes having a previous previa, having had a C-section, any instrumentation of the uterine lining like an abortion or a D&C, having multiparities. So if you have 2 babies in there, and they have 2 separate placentas, they have to go somewhere, and so one of them may end up lower than the other. And having back-to-back pregnancies, so having, Irish twins, I think they call them, but like one right after the other, where you have basically, a uterine lining that hasn't fully recovered from the last pregnancy, increases the risk. Problems with endometrial perfusion also increase the risk of having a previa, because remember, one of the reasons that the little zygote implants so high up during that initial phase is because the hormones make the endometrial lining so like engorged and full. But if you have advanced maternal age, so decreased blood flow, diabetes, decreased blood flow, hypertension, which causes constriction of the blood vessels and decreased flow, if you're a smoker, or if you use like cocaine or meth or any type of stimulant that decreases blood flow, or if you have fibroids or endometriosis, those all increase the risk of the fetus not implanting where it should and actually making it lower down. And then having a large placenta also increases the risk of it just having a portion of it that is lower than normal. So the treatment for this is frequent vital signs, oxygen therapy, IV access, fluids is needed to maintain a MAP and a mental status, monitor the patient carefully, and rapid transport, and they'll get a C-section at the hospital, which we do not do in the pre-hospital setting, even with medical control. So to contrast that, placental abruption or abruptio placentae is a separation and bleeding at the decidual placental interface. So this only occurs in about 1% of pregnancies, so it's pretty rare, but it's a premature partial separation of the placenta with the formation of a hematoma and or hemorrhage into the decidua. So if you remember, the decidua is the uterine lining where the placenta meets the uterine wall. The risks or causes of abruption include a previous abruption, history of C-section, advanced maternal age, so over the age of 35, having multiple pregnancies, so having 2 babies at once or 3, uterine fibroids, so having other things in there that take up space, eclampsia and seizures. So if the person has an eclamptic seizure or a non-eclamptic seizure, like they have epilepsy and they have a seizure, what the seizure itself can cause an abruption. Trauma is the big one. So trauma can cause an abruption, and that can be usually blunt force trauma, falling downstairs, being assaulted or abused, being in a car accident. Hypertension or anything that is a stimulant like cocaine, methamphetamine, smoking, excessive caffeine use, things like that can cause an abruption. And preterm, premature rupture of membranes, meaning that a baby before 37 weeks gestation has a rupture of membranes before the onset of labor. It can actually kind of like pull on there and rupture, or pull the placenta away from the wall and cause an abruption. HELP syndrome also increases the risk of abruptions. So the signs and symptoms are severe, sudden, intense abdominal pain and hypertonic uterine contractions. So when you're going between PREVIA and abruption, the patient with PREVIA, again, may have some contractions, right? And so you can time them: onset, duration, relaxation, onset. And so I can time the frequency and the duration of the contractions. With abruption, hypertonic uterine contractions means that this abdomen is going to be rigid and really, really hard and firm, and these contractions are going to be like one right on top of the other, and like there won't be much of a recovery phase at all if there is one. The uterus itself is going to be incredibly tender to the touch, and the abdomen is going to be distended. Additionally, the patient may have signs and symptoms of hypovolemic shock and nausea and vomiting. Treatment, however, is the same, and it's less important that you diagnose one versus the other. Just recognize the risk factors, and then vital signs frequently. Oxygen to maintain a SAT is needed, IV access and fluids to maintain a MAP and a mental status. Put them on all the monitors and transport them rapidly to the nearest hospital that does, C-sections or emergent OB care. Depending on the gestational age of the baby and the degree of the abruption, they'll do an ultrasound to kind of see what's going on. They may hospitalize the patient and give them medication to stop their contractions, or they may do an emergency C-section to take the baby out, especially if it's a significant abruption with hemorrhage. So let's talk about some high-risk deliveries. We're going to talk first about presentations that you cannot deliver in the field. And there are two specifically. One is a single limb, like an arm. So if you go to check to see if the person's crowning and there's like a little hand hanging out there ready to shake your hand, that means like, hi, it's time to drive me faster to the hospital. And then prolapsed cord, right? So those are the two things that we absolutely cannot physically deliver in the field. Presentations that you can deliver in the field if you have to. Head first, a normal cephalic delivery. That's ideal, and I wish everyone could choose that one if they could. A nuchal cord we can deliver, and again, we can reduce it or we could clamp it and we could cut it if we have to. And then we're going to talk about shoulder dystocia and McRoberts maneuver, and then we're going to talk about like a breech with buttocks or double footling breech. So what to do if they're coming out backwards. So single limb presentation. Again, transport. Cesarean is usually required, and the big key points for this are support the baby with your hands, provide an airway for the baby using your fingers if you can see, like head or face at all, and transport immediately, and do not attempt delivery in the field. You want to keep the presenting part warm, so, keeping it covered is important, and then you want to try to take pressure off of it. So if you could get mom into like the knee chest position, or at least kind of into a Sims position, like on her side, that may help as well, and I'll show you a picture of that. So again, single limb presentations are rare, but typically it means that the baby is sideways in there and there's a single arm hanging out, and it's not physically possible then at that point to deliver that baby because you need the body to come out either head first or feet first. It can't come out sideways. The prolapsed cord is another emergency that we really cannot deliver in the field. Now, if mom is like actively pushing and we can't stop the delivery from happening, just know that because of the compression and the forces against the cord, we may have a resuscitation on our hands. But ideally, you know, we will get there soon enough and we'll get mom into the correct position, or the pregnant person into the correct position, and then we will get them to the hospital where they can have an emergency C-section. So the prolapsed cord occurs when the umbilical cord falls into the vagina, the birth canal, and is compressed between the fetus and the pelvis. So immediate care is required to prevent essentially suffocation due to compression of the umbilical cord. The treatment is aimed at keeping the head out of the vagina, out of the birth canal, and off of the cord. So if you can see the umbilical cord in the vagina presenting before the baby, you want to put the mom in this knee chest position. If she can't tolerate it, you know, ambulances are scary, and now you're asking somebody who has a really weird, you know, center of gravity to try to transport like that. You can pad them with pillows like that bottom picture. Just make sure that you pad them significantly so that there's no pressure on the abdomen that's forcing the fetus up towards the pelvis. So lots of pillows to try to, you know, get the bottom in the air. That would be okay as well. Remember that your hand is going to stay in the vagina the entire time, so you need to put them in a position in which you're going to have access. So next, obviously with a very sterile glove, you are going to, and a towel or sheet or something for modesty, check the umbilical cord for pulsations. As long as it's pulsating, then, you know, ideally we're good. If there's no pulsations, you're going to need to try to get in a little bit deeper and try to move the presenting part of the fetus off of the cord. So just very gently, and remember, we're not trying to like push our fingers into the fetus. We're just trying to alleviate the pressure between the fetus and the bones. So somewhere the cord is stuck between the pelvic bones and the fetus. So very gently, you're going to insert your hand into the vagina and push the presenting part. So that's usually going to be the head, with the flat part of your fingers in your palm, using as much surface area of your fingers and palm as possible to kind of lift or move the baby off of the cord. Be really careful that you're not pushing with your fingertips. If you are female and you have fingernails, like now is the time that you wish that you had kept them short, but do not, you know, ideally you won't have long fingernails in the ambulance, but you know, short fingernails, no fingernails to the fontanelle, and so really that's what we're trying to avoid, is pressure directly on the fontanelle. And then recheck that cord for pulsation. So you want to like kind of keep your hand's going to be stuck in there. So you got to keep your hand there. You're going to make sure that you can feel pulsations in the cord. Administer high flow oxygen to the mom, ideally IV access to the mom. Transport immediately. Let the hospital know as soon as you can that you're coming, because they're going to have to ready the OR. And then you're going to continue holding the presenting part of the baby off of the cord the entire way. It's not till you get to the hospital, it's till you get to the OR. So be prepared to stay in that position, and probably, you know, sitting on the bottom of the stretcher or riding, so that you don't, you know, walking would be awkward and you'd be bouncing up and down, you'd lose the pressure. The most important thing is that you don't let go of that pressure and cut off flow to the baby. So yep, you'll go all the way to the OR and stay there until the C-section is performed and the baby has been lifted off of the cord through the opening in the abdomen. All right, so things that you can deliver if you have to. So let's say we have a baby and it's coming. We get there and mom says, or the pregnant person says, I feel the urge to push. And you look and there's definitely crowning, and you know, the head comes down and the baby lifts up, and you feel, and there's no nuchal cord, and the head rotates, and the baby starts doing this thing that we refer to as like turtling or turtle sign, where it goes out as she pushes and then comes back in or retracts back against the perineum after it emerges. So this baby looks like it's wearing like the perineum is a big turtleneck. So in shoulder dystocia, the infant's shoulders are larger than the head, and labor progresses normally, and the head is delivered, and then the shoulders become trapped between the pubic symphysis and the sacrum, and so delivery can't occur. So what you want to do is pull the knees backwards towards the patient's ears and out to the side. So what you're really doing is aiming the knees towards the shoulders. So you want to get the knees open and up on both sides as much as you can. And you can notice here that the point of pushing is the foot towards the knee and the knee towards the shoulder. And then you're going to, with a fist or a firm hand, push. And these are not compressions, not like CPR, just firm, constant downward pressure just over the pubic symphysis. So suprapubic pressure to untrap that shoulder from behind the pelvis. You're not going to pull on the baby. You're not going to do any fundal pressure to try to expel the baby, and nothing else. So this is approved for EMS use. It's called McRoberts maneuver. And again, you may have to help that anterior shoulder come down, and then the posterior shoulder come out, and then the rest of the baby should come out very easily. But what this does when you bring the knees up is it actually further opens and aligns the pelvis and allows for this larger baby to deliver. Then we have our buttocks or double footling breech presentation. When you look and the presenting part is either a butt or 2 feet, or technically 1 foot, and then the other foot could deliver. You know, again, we can deliver this if we have to. Ideally, we would not, but if the baby is coming out, the baby's coming out. So position the mom on the edge of the bed or with the hips elevated so that like the body elevated up on pillows or something, so that you have some play. And then flex the mom's legs open like you would for the McRoberts maneuver. Support the legs and the body as they deliver. So as you see here in that first picture, there's like an arm underneath and then an arm over, much like when you're doing infant CPR, how you kind of like sandwich the baby to flip it over. You want to have a really firm grip on this baby. Now remember, this is not a dry baby. This is a wet, vernix coated, slippery, limp baby that is not going to assist you in any way with the removal process. Okay, so this is just a really wet, slippery baby. Okay. So support the baby, and the body will be delivered kind of with the contractions, and the arms and legs will kind of flop out. Okay, now you've got a head stuck in there. Now remember, in most babies, the head is the biggest part. Now the problem is that the squeeze has already occurred at this point in time, and the cord is out, and the compression has been alleviated from the chest, and the head is stuck in the vagina and the baby can't breathe, right? So we need to now get the head out. So a couple things that you can do. The first is to tuck the chin. So typically when babies are born, and the way that they normally deliver is by flexing the chin towards the chest and delivering that top part of their head first, and then they extend the chin up as they deliver through the perineum. So you need to kind of reverse that process and tuck that chin and deliver the chin first. And you can do that by kind of lifting the body gently, okay? But we're not going to pull on the legs. Just lift the body gently and allow the head to kind of deliver chin first and then head up. If you can't deliver that way, then at least try to create an airway for the baby using, again, sterile gloved hand to kind of form a V to allow air entry to the infant's nose. Okay. And if the baby is stuck, you're not going to pull and do anything crazy, just transport, providing an airway for that baby. So let's talk lastly about some post-delivery care. Meconium aspiration or meconium aspiration syndrome occurs when the baby is stressed in utero and the fetus has its first bowel movement before it is delivered. And so now the meconium mixes with the amniotic fluid and it becomes this really thick kind of pea soup looking liquid, and as the baby is practicing breathing and it's drinking and eating, the meconium actually ends up in the nasal passages and in the mouth and in the airway and obviously in the GI tract, which is not concerning because at this point in time it doesn't have any bacteria in there. So what does concern us though is that this is really thick, and because it's mixed with the vernix and the lanugo and everything else, it creates these thick kind of meconium plugs that can actually obstruct the airway. So the signs and symptoms of a baby who is not just meconium stained, but who has meconium aspiration problems is a non-vigorous newborn who clearly has meconium in their airway. So they have the mec stained amniotic fluid, and then you can see the meconium in the airway. When you go in and suction or go to intubate, you can see meconium below the glottis. There's meconium at the level of the cords. So these are kids who have respiratory depression at the time of birth. And the cure for this now is suctioning. So remember, we don't suction at the perineum anymore. We don't suction routinely mouth and then nose for babies who are vigorous at birth, because the amniotic fluid actually has antibodies and stuff in it that help prevent babies from getting sick. So we want them to have that still in there. We don't want to suction that out. We want them to swallow it, and that's fine. But for these kids who are depressed and who clearly have evidence of meconium, we want to do direct tracheal suctioning, especially if they have bradycardia, apnea, or hypotonia. So prepare for immediate resuscitation. So this is going to be, intubation, suctioning out the airway, oxygenation, positive pressure ventilation, and then start compressions if they have bradycardia as well. On the mom side of things, postpartum hemorrhage is a concern. You should be checking every 15 minutes the vital signs and the fundus and the lochia, right? So the primary causes of postpartum hemorrhage are retained placenta. So remember, you want to look at the placenta, make sure that doesn't look like there's a piece of it missing. Uterine atony. So that occurs when usually for the ambulance, it'll usually happen when the bladder is full. And if the bladder is full, the uterus can't contract. And if the uterus can't contract, it just hemorrhages. So uterine atony leads to this big, boggy, displaced fundus. So the fundus should be firm and it should be midline. And it should be below the level of the umbilicus, especially while we're with the patient. So if it is like big and kind of soft and squishy and off to the side, displaced off to the side, that patient has a full bladder. Lacerations to the cervix, to the vagina, to the perineum, all can cause bleeding. Hematomas also, especially from big babies, can cause internal bleeding that we can't see. And then a ruptured uterus could cause internal hemorrhage as well. So these are all things that could cause postpartum hemorrhage. In the non-immediate postpartum period, so like, a week or so out, the person also could have that endometritis, where they call the ambulance with that, discolored discharge and fever and abdominal pain and cramping, and that could be a secondary postpartum hemorrhage. So the treatment is to have them urinate, to massage the fundus, and again, you're going to support that lower uterine segment first, and then you're going to massage the fundus to get it to to contract, to become more firm. And this isn't just like a 2 or 3 time thing. You're going to do that for, you know, up to like 15 to 20 minutes to make sure that it's like, you know, tight, and it hurts. Okay, so I'm just going to tell you now, it hurts when you do fundal massage. So don't expect them to be like, wow, that feels so nice. Can you do my feet next? That's not what they're going to be like at all. They're going to be like, oh my gosh, that hurts a lot, because you're causing the uterus to contract. Okay, so it's going to feel like they're having, you know, contractions again, which is what you're causing. You can put the baby to breast if mom is stable, and the stimulation of the nipples will actually help the uterus to contract. Treat for shock, so again, oxygen, IV access, fluids is needed, and then transport. And then oxytocin or Pitocin is the drug of choice for postpartum hemorrhage. Other drugs like pressors, things like that, actually are not effective on postpartum hemorrhage for like vascular constriction. So those are not going to be effective, and as a matter of fact, they actually might make this worse. TXA, there is some literature that supports the use of TXA in a postpartum hemorrhage that's refractory to oxytocin, but for right now, let's stick with oxytocin, and you can do that IV or IM. So how do you estimate blood loss, right? So basically, we're saying you need to check the person every 15 minutes for hemorrhage, but then we give you these pictures and say, this is what a hemorrhage looks like over an hour. So you're going to look at vital signs, right? If they're getting tachypnic, tachycardic, hypotensive, if their end-tidal CO2 is rising. You know, the second that you're concerned that somebody might be hypoperfused, if you put on that end-tidal CO2 and you see this rising, you know that you have an issue. So if you kind of think about like what it would look like over 15 minutes would be roughly a quarter of this. So a scant amount is basically just a small, less than an inch, or, you know, just one wiping. A light amount is less than 4 inches in an hour, so less than 1 inch in 15 minutes. A moderate amount is less than 6 inches in an hour, or less than 1.5 inches every 15 minutes. And a heavy amount is saturated peripad within 1 hour. So anything more than 1.5 inches. So, you know, in 15 minutes, so like, you know, 2 inches or more in 15 minutes would be considered, you know, significant blood loss. So just keep an eye on the blood loss. And again, vital signs are going to be one of your key indicators. So urinate, fundal massage, baby to breast, IV fluids, and then oxytocin, and drive faster. The last thing that, you know, we need to cover is this amniotic fluid embolism, or an AFE. These are incredibly rare, but similar to like DIC, they have an 80% mortality rate. Amniotic fluid and fetal debris can enter the central circulation when the placenta is tearing away from the decidua. There are open blood vessels, and if that at that point in time there is amniotic fluid right there, it can just kind of spontaneously be taken up into the bloodstream. And then it travels to the pulmonary vessels, where it gets caught just like any other embolus, and because it has all those proteins and those lipids and those carbohydrates, but it also has like the hair and the vernix and everything, so it has the lanugo and the vernix in it, that, remember, belonged to the baby. The maternal body recognizes then that as like a foreign substance and starts to have like basically an anaphylactic reaction to it within the pulmonary vasculature. And so then there's this huge inflammatory response within the lungs, that, you know, where the blood vessels get like really congested and just kind of like shut everything down, and the person will become a sudden onset of hypoxia, tachypnea, tachycardia, and you know, there's no treatment that we have for this in the ambulance. So getting them to, a high level of care as fast as possible is important. So supportive care, rapid transport, standard resuscitation is what we have for tools in the ambulance. And I did mention that pregnant women are increased risk for DVT and PE, which can occur at any time during the pregnancy and is at highest risk in the immediate phase following a C-section. Okay, so that is pregnancy and labor and delivery in a nutshell. Thank you, as always, for watching. Let me know if you have any questions, and I'll see you at the next video. Hey, it's Nursinga, so thanks again for watching. Be sure, if you want to see more videos, to click the subscribe button. If you want to follow the Summer EMS Paramedic Lecture Series, click on the link below to sign up for notifications and see what else we have to offer in our Summer Lecture Series. Take care.